excellent talk, Anshu, and I think it was very much in keeping with the theme, future of hepatology, because the problem that you highlighted is for the future, because as of now, the adults don't see any biliary atresia. You open for questions.
I sometimes wonder, Anshu, that we say we fail miserably, which you said, I mean, all of us endorse that. Is it something to do that our disease is, I mean, are they more fibrotic? Is there, like, what we fail to understand is our surgeons, while they, how we are failing. Is it only with delay, referral? And actually, there is a paper which came, which Richa had shared at that time, where she showed that in the first decade and second decade, when she was working there was a transfer which came early. Patients still came early, but probably not many people come early. So while you're talking about fail miserably, do you only mean those who come late, or do you mean that even those who have done surgery at 60 days, 90 days, they still do bad?
See, I think it's both. So one, they are coming late. That's a very important problem. Second, if they are coming in time, the moment you tell them that this is not a curable disease and the patient will need a long-term follow-up for one or the other related issues, even a 50 days old, the parents will say, we do not want to get operated. So that's the second step, stopping point. The third stopping point is, okay, the surgeon operates. We don't have 60% results, but we have around 30-35% result, which is not bad if 90% get operated at less than 2 months of age. So our results need to be improving. Fourth is the post-Kasai potoenterostomy care. They come with episodes of cholangitis, they require long-term antibiotics, they require, at every step, even if they are operated, even if they have bile drainage, they require financial and social support for the rest of their life. This is a disease which cannot be tackled without finances and psychosocial support. Yeah. So we are failing at all levels. That is my own understanding. That
Also, I think we have to acknowledge the fact that it's a disease of the poor.
Yeah.
And that's why, the degree of cholangitis that we see is, you don't really see that in the Western world, and it's got something to do that we don't understand. It is definitely a disease of the poor.
I agree. Most majority is from the lower socioeconomics.
Cholangitis in itself, the prolonged situation, and 1 or 2 weeks therapy, and then you have to afford the cost of the therapy.
And we have good, like in our own hospital staff, patient's child who's been operated is now 30 years, sir. And she has just got a small spleen, and that girl is 30 years and doing very well. So it's not that they are not there, but they are a minority. No. Just the regular ones got operated in time, but lucky. But I can count them on fingers, and I can there are very few.
You don't even know how many of them are eventually going to end up requiring a transplant.
Yeah.
We have not transplanted so many kids. We done a Kasai at the age of 50, 60 days when they're 20, 21, 24. Because portal hypertension is there. It doesn't go away. The other thing, you mentioned hepatocellular carcinoma 1%. So we've looked at our explants for biliary atresia. It's more than 5% of hepatocellular carcinoma when you actually look at the liver out. So, it's hard to pick it up. It's already starting. And obviously it can manifest.
So maybe because when I was going through the literature, they have reported up anywhere up to 2.3% in the transplant.
So
yeah.
This is different to what you would see. Ava?
Yeah, very grounded talk, Anshu, as usual. Thanks for that. I have just one comment. We have seen adults, patients growing into adulthood as an adult physician, and most of them have only portal hypertension. They have never bled. They are growing well. Their LFTs are pretty good. I mean, what would you do, Anshu, Anupam, for these patients? Big spleens, big varices, but never bled, and very well. So this is a subset that we have seen.
Big spleen, big varices, you would have to offer them prophylactic therapy.
Yeah.
So I would say you need to just closely keep them under follow-up, and the point will come that they are wanting transplant, you would have to consider them for transplant.
Liver dysfunction is there or not. If they are concomitant dysfunction, then certainly they should be taken for transplant.
Yeah, but that's not Abba's question.
Yeah,
That's the
my
easy
question.
one. If they have liver
Yeah.
dysfunction, it's the liver function is
The
normal.
liver function
and
is
they
very
are
good.
So you keep monitoring them and hope.
Yeah,
hope
you
that
would
they
not
reach
transplant
61
them
with herd
prophylactically
immunization.
because of that. I would not.
I said if they are.
Yeah, yeah.
I never said that
No, I'm saying, sir, that's the easy
if
bit.
they are.
If they have liver dysfunction, then the choice is easy.
Easier.
It's when
Yeah.
they don't have it.
Exactly,
Yeah,
Dr.
exactly.
Abba. It is not easy to have the viruses. If you have gastric viruses there, they are likely to bleed. They can bleed any time. You never know. And they have hypersplenism. If these two factors are there, then certainly you should go for transplantation. I would not wait and buy time.
If somebody's not bled, I wouldn't offer a transplant to them. They can die after a transplant,
Yeah.
no matter how much we clap ourselves
So
on the
that's
back.
the
It's still
dilemma.
90%. There's 10% chance of mortality at liver transplant. And after having been around for 30 years, you replace one disease with another after
Sure.
transplant, frankly.
Yes.
Geeta.
So I just want to know the PFIC patients who are diagnosed, genetically diagnosed, and they go into adulthood. Do you advise them regarding medications they should and should not take? There's a list of medications, like you said, many drugs can cause drug-induced cholestasis in these patients. So do you advise them on that, or is it an advisory? And second, how would you advise when they get pregnant?
And the advice about the drugs are clear-cut. The ESL guidelines are saying that if there is diagnosed BSEP, then these drugs, the amoxicillin, the piperacillin, the OCPs, the androgenic steroids, and some of the antifungal drugs have to be avoided because they inhibit BSEP. For all other types of PFIC, there is no advisory as such, and there are no guidelines as such, and there is no recommendation that these drugs will affect the other genetic conditions. Regarding pregnancy, I haven't read, so I don't know. They should do well. I think so.
Yeah. Thank you very much, Vikrant, Anshu, Neelam. Excellent presentations.
Anupam, one question.
One last comment, yeah.
About BSEP.
Yes.
Is it that those who have BSEP are more likely to develop these drug-related problems?
No, ma'am, there are a list of these 80 or 90 drugs which inhibit BSEP at various grades of
No,
inhibition.
so what I'm saying is, if with amoxicillin you were
Yeah.
to develop drug toxicity, would
Yeah.
you look for BSEP? Other way around.
Yeah, if it is a severe delay, yes, you should look for severe delay.
So there's another
Even that
subgroup.
guideline says
Yes.
acute severe delay should undergo a genetic
Right.
testing as per ESL now.
The other group which is not mentioned there is acute viral cholestatic hepatitis which goes on for 2, 3, 4 months. Whether you should be looking for PFIC, I mean it's worth
Yeah,
a
that is
research
something
topic for
something
you.
interesting. We did it. We also thought the same thing because these patients had low GGT, acute viral
Yes.
hepatitis A,
A,
presenting
low
with
GGT
prolonged
and going
cholestasis for
on
more than 3 months.
Yeah.
We thought of it. We did only 10. We didn't do more than 10. In first 10, we did not get, and we didn't have funds and all, and
You gave up.
we stopped that testing those. We don't know,
But
but it
that
is
is-
something worth looking up. Yeah.
Thank you, and big thank you, Dr. Yacha, Maya, Prashant, and to everyone for all the interactive bits.